Hi, everybody. Welcome to another IPC Partners Journal Club. Delighted to have Dr. Jude Robinson with us today to talk about her selected paper. Good morning, good afternoon, good evening, wherever you are in the world. And if you're watching on the recording, thanks for tuning into the YouTube channel. Jude is going to be talking about empowering patients to improve hand hygiene, which I think is a really pertinent subject. We always think about hand hygiene anyway, from my perspective, about our healthcare professionals, and maybe we don't think enough about patients, particularly those who can't use our traditional hand washing sinks and facilities. So really interested to hear Jude's thoughts and perspectives on that. Before we get into it, just to remind you, like we always do at the beginning of our journal club, what we're here to do and talk about. IPC partners run these journal clubs quite regularly. We're typically offering a journal club every 2 weeks, completely free for you guys to attend. We like to try and bring insight to a topical IPC published paper. We also like to try and have a bit of fun and generate a bit of a discussion afterwards. And we really, really do value your input from the audience. So please use the Q&A section in the top of your toolbar for any questions that you might have for Jude, John, or myself. And please use the chat if you'd like to share some of your own experience about maybe how you've improved patient hand hygiene in your own organisations, or some of the challenges or barriers or even facilitators to improving patient hand hygiene. Like I said, we'd like to have a bit of fun. Please just chip in with your ideas and thoughts and ask questions, because it really does help generate discussion at the end of it. Okay, without further ado, I'm delighted to welcome Jude. Jude, is this your second or third IPC Partners Journal Club?
I think this is my second one where I've critiqued the paper. So yeah, I'm really excited to be here. So thanks for having me.
Yeah, but you've been on
And
others. You've co-moderated
yeah,
them
I've
as
been on
well.
others.
You're an old
I've been
hand.
like part of the furniture.
Hey Jude, can I just put some pressure on you?
No.
Just a tiny little bit of pressure. I want to be inspired today because
Okay.
we've been talking about hand hygiene and patients. I mean, more generally about patient engagement in the IPC agenda for decades, and it just doesn't seem to be coming to fruition. So I'm really looking for some practical inspiration here. How can we actually kind of get over whatever inertia hurdles that we've built up or are building up around us, and actually just find ways to productively engage patients in directing their own journeys?
Great. Well, I will do my best. So again, thanks so much for inviting me to come onto this journal club today. And when John and Phil asked me to talk about this, I was in the middle of reading a blog, which really inspired me to pick this paper. I was reading a blog by Jules Storr, which was called "Can Patients Help Prevent Infections? A Conversation Continues." And what Jules does in this blog is really give us the background to patient involvement. And as John has just alluded to, this is a really well recognised concept. There's a paper, McGuckin et al. From 1999, who look at patient empowerment around education, and actually a bit like what this paper's done today that I'm going to talk about, to get patients involved in monitoring hand hygiene, and that was in 1999. So although these authors here suggest that this is a novel approach, it absolutely isn't. So yeah, this blog that I read from Jules, and Phil's going to put a couple of papers in the chat from that. It'd be really interesting for you to read at a different time. But what Jules also suggests as well, and tells us about, is that the World Health Organization have just published back in March 2025 their first ever research agenda on hand hygiene. And what they see in that, and what this expert consensus group decided, was that there was 6 thematic domains, and actually patient empowerment and patient participation is part of that research strategy, which will run through to 2030. Sorry. So yeah, this was really apt, and this paper came to my attention, and I thought, you know what, I want to critique this a little bit. And I think what these authors do, Watanabe et al. So they're based in Japan, and what they start by doing within this study is what we all know, it's our bread and butter, but hand hygiene is the cornerstone of infection prevention. Yes, it is. Tick. but also just recognises this suboptimal compliance that we just see across the world. Recognising some of the traditional approaches that are used already, so such as education, audits, and the feedback that we do in our day-to-day work. And as I said, you know, they really see this as quite a novel approach, but it really isn't. And it might be for Japan and that side of the world, but it certainly isn't as novel as they perhaps think it is. So moving on to the designing methods then. So what I loved about this study, it had a really clear aim. So the aim of the study was to evaluate the effect of that patient empowerment hand hygiene programme on healthcare workers' hand hygiene compliance. So when we look at the design, so it's a single centre observational interventional study. So we know that that there are some limitations to the single centre study. It's been carried out in one hospital rather than a diverse settings if it was to be done in several. So we've just got one snapshot here. But what the researchers have done is assigned an intervention over a period of time to see what happens rather than looking at what's happening already. So we've got this active intervention that they're put into place. You can see, obviously, there's limitation to that design in terms of that external validity, and there is some selection bias, which we're going to talk through because it kind of it's an ongoing theme I felt throughout the whole paper, this selection bias, which we could discuss. So we can see it's a reasonably sized hospital. You know, it's got 20 general wards, 3 intensive care units. So, you know, they've picked a decent site really to do their intervention study. And actually what was really clear is that their intervention was all about having a model which involved patients. So it was removing that responsibility solely to staff. It was sharing that responsibility to patients as well. Okay. So when we looked at the study duration then, so they had a baseline. So they through January 2020 and November 2020 was their baseline time. So that's where they looked at some compliance data. But what was interesting, and they were very open about this, was that actually they weren't very good at it. So there was lots of gaps in the compliance data, which again, they compare later on, and then you kind of debate whether that's actually helpful or not. And then, of course, the intervention was December 2020 and April 2021. And all of you, I'm sure, are thinking, this was through COVID. Absolutely. So bear that in mind as we talk through it. So the intervention itself then was they put touch-free alcohol-based hand rub dispensers outside patient rooms. And they said away from the bedside, which again, I was a bit like, it's a strange thing to do. And then they gave all nurses, and they called them floor nurses. So I've written that in my slide, but I presume they just mean frontline nurses. And they gave them all a portable alcohol-based hand rub, so they had it on them. Interestingly, they didn't give them to the doctors, which again, it's another worry, isn't it? It's like, why are we just focusing on nurses? But that's another story. We'll come back to that. And then they focused on who moments before and after contact. Again, they didn't do all the 5 moments, but they just concentrated on before and after. The hand hygiene events were monitored across patient days during that intervention, and that was one of their primary outcomes. And we'll talk about those in a moment. But then they also they used hand hygiene events per patient day, but then calculated by dividing the monthly usage of alcohol-based hand rub, including those portable ones on the dispensers that they put up, by the total number of patient days in the month. So they're thinking about here already how they're going to collect some of this quantitative data. They then also used the per push of alcohol-based hand rub, and they fixed that like 1.2 mil. And that usage was then calculated based on the amount of alcohol-based hand rub supplied to each ward. So there's quite a lot of thinking behind how they were going to get some of this quantitative data. And then, as I said, they did try and compare the data before and after the intervention to evaluate that impact. I'm just checking my notes. I've not missed anything that I wanted to say about that. That's okay. Great. So when we move on to the participants then, so it was a fairly big hospital. They included 19 out of the 20 wards, and they excluded the mental health ward. Again, they didn't really give any rationale to that. They didn't say what sort of mental health ward it was. I would have liked to have known a bit more about that. It might have been that some patients might have been able to take part. So again, I would have liked to have known a bit more about that. And then what they did was they decided, with what data they did have on compliance, they targeted those wards that fell below the average of hand hygiene events for their general ward areas. Interestingly, the way they selected their inpatients was a little bit subjective. So it was based on the healthcare workers' judgment on whether they had sufficient communication abilities. And when you actually look at, I've actually got the quote somewhere, it's on my last slide actually, I'll bring it up later. It was something about was conscious, and was fairly fit and well, and you think, well, actually these people are in hospital, so you can't really guarantee that their health's going to be okay. So yeah, that was a bit subjective. And then the inpatients, of course, were doing the observations, and they were only checking on nurses and doctors. Now, you may have found, I couldn't find anywhere any mention of any multidisciplinary professional outside of nurses and doctors. I may have missed it, but I couldn't see it, and I thought that was a real shame. And then another part of that selection bias was the head nurse, head floor nurse, I presume they mean ward managers. They could just decide if their ward took part or not. No, it wasn't, they didn't have to, again, which is a bit of a shame, I suppose. So yeah, there's just a few considerations around the participants. So then when we move on to the intervention itself, so they talked about 3 components, and I'm going to be completely honest, the third component I couldn't get my head around, so we're going to skip past that one. But the first component was really about how they managed to kind of get patients to be empowered to take part in this. So they started that by they would educate the patient around the alcohol-based hand hygiene when entering and exiting, by the nurse that was looking after them. So they'd have that little bit of education around hand hygiene, which of course they would need to do to be able to take part in this, which was great. The patients were then asked to do an anonymous checklist, so they weren't taking down anybody's names. It was just like, whoever came in, did they do hand hygiene? Did they not? And if they thought that possibly they carried out hand hygiene out of sight, which is very likely because of where they put the dispensers, they could stay unclear. I think one of the frustrating things, and maybe it's just because of word count and stuff, like I couldn't see the detail around how they might remind staff to wash, to use the alcohol-based hand rub. I think that little detail would have been quite nice. We've got no data to say how many patients declined to be involved in the intervention. And also another sort of disappointing factor for me was that no feedback was given to the patients that took part, and feedback seemed to be given to the wards on the compliance side of things after the programme. So didn't really see that altered behaviour during the study, rather than, I suppose, at the time when somebody was reminded. So I felt that was a real missed opportunity, and kind of goes against what we do day to day, where it's all a bit more like live feedback and in the moment, so we can learn and provide that education, in a kind way. So I felt that there was a bit of a missed opportunity there, but you might think differently. Then the second part, so this is really about how they kind of derived their quantitative data. So what they did was they estimated how many healthcare worker contacts somebody would have in a day, and they suggested it would be on average around 10. And that was based on whether they went in for personal care, medications, any other healthcare activities. So that was just set at 10. And then that was obviously multiplied by 2 because you want before and after hand hygiene. They then the actual number of events were then calculated at the end of the day by dividing the consumption for that day by the push 1.2 mil. And then, as I said, there was a third component, which kind of it almost conflicted the not giving feedback, because this suggested that the nurses would get together And actually, if their target number was not achieved, then they'd have some discussions about the implementation status. And what I found confusing about this, it doesn't take much to confuse me, is that they were then using definitions that they'd not actually presented before. So it's hard to kind of know where they were coming from with that. So I thought they could have explained that a little bit better, particularly as they said that they weren't giving feedback till the end of the programme. So hopefully that gives you an idea of kind of what the intervention looked like. And I felt that was quite well thought out. Again, they were really thinking about that quantitative data to help support. So when we look at then the outcomes and the analysis, so they had primary and secondary outcomes. So no surprise that the primary outcome was around the average number of hand hygiene events per patient day. And then they also looked at, from the secondary outcomes, was hand hygiene compliance rates, incidence of HCAIs per 10,000 patient days. And then they did some correlation as well between the prompting and hand hygiene event frequency. So from an amateur, I will confess, around the statistical side, it appeared to me to look like they'd used reasonable testing. So they'd used the 2-sample t-test, the Mann-Whitney U-test, they'd done some correlation, they'd used the Pearson product moment correlation coefficient. I think one of my observations here, and again, I'm no expert in the quantitative side of stuff, I didn't see that adjustment for confounders. And if they did, they just didn't report it very well, and it may well be that they did. So when we actually look at some of the numbers itself then, which is on the next slide. So when you look at the primary outcome data, so the average number of hand hygiene events per patient days across the wards, they said increased from 23.4 during the baseline to 37.3 during the intervention. So we can see an increase there. The hand hygiene compliance rate, which they said was checked by the IPC team, which they had already recognised wasn't very good or very robust and a bit missing, was 38.5 during baseline. So that may have been different if they'd had the complete data, and that had jumped to 45.2 during the intervention period. We can see here that the authors have shared some p-values. So you've got the MRSA incidence. There's a typo there, sorry, it is meant to be 10,000 patient days. So that was 1.86 at baseline, and it's jumped to 0.49 during the intervention. So we see a bit of statistical significance there, but not on the other organism there. That wasn't felt to be statistically significant. Now, these are the next sort of findings are much more simple and probably a bit more my level, if I'm honest with you. So I quite like this slide, although it's very, very simple. Is that what you see here is the increase of patients taking part in this intervention, which I think is quite cool. You know, as it starts, she had about 60 patients taking part. In January, it jumps right up to 496. Another 100 patients taking part through February, and then jumps up by another 150 or so in the March. So something's happening here where patients are feeling like they can take part. There's some feasibility suggested here, which is great. And although soap use wasn't part of the outcomes at all, they did see an increase in soap usage of 34%. So when you look at the wider literature, it's a little bit lower than what other studies have shown, but not far off really. So I think their key finding really is that their programme did contribute to increased hand hygiene events. So strengths then. So I felt, and say it'd be interested to know your own thoughts, in terms of loosely innovative, because I guess it's not really, but because we should be including patients in infection control, but you can say it was quite an innovative intervention, and what we did see was patient participation, and that patient participation increasing over the intervention period. And we've seen some quantitative outcome measures, which can be quite tricky to do with these sort of studies. So I think they've really tried to do that. And we've seen with that increase in patient participation that it's feasible, and it's cost nothing, hasn't it? It's a real low cost strategy. You might say that there'd be a bit of nurse time providing that initial education, but on the whole, it's a fairly low cost strategy. And then our limitations then. So we've already talked a little bit about it being a single centre study. So that lack of generalisation and that ability to be able to do that. And I think I would really have liked to have seen from the paper if there were any other hospital-specific factors like staff knowledge. Did that prevent them asking patients to participate? That patient selection, that could have been a bit more robust for me. And actually what the paper said was that the selection was whether they were conscious or sufficiently healthy patients. And as I say, I think you could loosely define what that sufficiently healthy patients is when they're all in hospital. And we do know that these types of studies can be difficult to replicate. So you may look at the implementation period and think that's quite short. But actually, when you look at similar sort of intervention studies, it's about right. And when you look at the 1999 study, I'm looking, they did their intervention for 6 weeks. So, and that was a long time ago, but you can see actually they have tried to probably have that intervention period for as long as sustainably possible. But what we do know is that with shorter periods like that, your effectiveness might not be as well confirmed as we'd like. I think some of the cultural and individual barriers, was missing here. Thinking about the country that we were in as well, and some of those perceptions. And I think it was a real missed opportunity to not speak to patients that had done the study to see how they felt about it. They do bring in some wider literature around that, but they hadn't looked at that themselves. As well, we all know that hand hygiene events don't always capture the quality of hand hygiene. So the hand hygiene event might have happened, but actually, was it good hand hygiene? We've already alluded to the fact that some of the baseline audits weren't completed, so we've not got those steady numbers. This was implemented through COVID, so that's got to have been a confounder, and it would have impacted hand hygiene behaviour. And they do actually recognise that. That's the one confounder that they do recognise and listed their own limitation. But other factors that might have confounded, I don't think have been considered. We've talked about selection of patients. And then, for me, I think a limitation was having that almost too much flexibility about who can take part. And some wards did the intervention several times, some not at all, some repeated. So it's a little bit, not quite as robust. And I think that's a little bit of a limitation, really. So moving on to our last slide, which is what I think this means for IPC, and it'd be great to hear what you think. Is that, I actually, I'm a complete advocate for patient empowerment, and I think that patient empowerment can enhance hand hygiene compliance and other IPC compliance. And I think this is quite a promising tool here that's been provided through these authors. And I think this could be a real great addition to our traditional hand hygiene strategies. And I think just one of the points that you raised, John, and I probably haven't given you what you wanted quite from me. I just don't think we give ourselves enough time to do that strategic thinking, sometimes on where we might want to change a direction on how we might be wanting to monitor hand hygiene. And I think sometimes just taking that step back and having that time to reflect and look at those other avenues. This to me seems like a no-brainer. The patients are sat there often with nothing to do, waiting for visitors, waiting for medical teams to see us. For me, it's an ideal opportunity to get them involved. And I think it really supports this culture of shared responsibility. Infection control isn't just the responsibility of those working, it's those that are accessing care too. And there's a lot that they can do to keep their own care safe. For me, some further work, I think we need to think about the sustainability of projects like this and those broader outcomes and those more longer term impacts. I think we've definitely got to be exploring some of those cultural adaptations across the healthcare system, with the diversity of our populations. And I really would like, and it's very hard to measure infection rates, particularly if you've got low infection rates to start with, but certainly working on that patient satisfaction and the healthcare worker perceptions would be really, really helpful to help anchor sort of any projects that we might do ourselves. So that's me done with my critique, and I'll hand back over to John and Phil for any questions that you might want to give Phil and John, by the way.
Yeah, no, we'll send them straight back to you, Jude, don't worry. So no, fantastic presentation, really clear, succinct summary of the strengths and the limitations, and actually some of the uncertainties about how the information was put across. So really great job as ever. So well done. So question from Colette straight away is, they measured alcohol gel consumption, but they also had personal alcohol gel provision. So did they include those personal gels in the overall consumption?
They did, yeah. Yeah.
Okay, great. And just a kind of separate question on methodology. I was a bit fuzzy myself about what the feedback mechanism was from patients. So they had the anonymous form, but did they also ask them to challenge staff? Was that part of their intervention?
Well, it should suggested so in the introduction, but they don't really talk about that bit. And I was a little bit confused myself, because what's the point in doing that if you weren't going to challenge and change practice and get that moment in place? So presume they did, and they just didn't explain it very well. Otherwise, it's a bit like, well, why would you be doing this then if you're not going to kind of get them to wash their hands before they touch you or provide care? Yeah, it was missing. I felt that was a real missing part.
Yeah, I agree. I think perhaps it was kind of hidden in the education, because that was definitely part of the intervention, was to educate patients on the importance of hand hygiene.
Yeah.
And probably a reasonable part of that would be, please feel free to challenge the healthcare providers. I just want to reflect on that, really, and what a big ask that is of our patients. Because if you're a patient in a hospital, you're in quite a vulnerable position. I think it's quite easy for us as healthcare providers to underestimate how hard it would be to challenge a healthcare provider about anything, hand hygiene or whatever it might be. I visited somebody in hospital a couple of years ago, and I saw a member of staff going patient to patient to patient in a bed with an obs machine, no decontamination of the equipment or hand hygiene inside. And I said to the person I was visiting, let me just have a chat with them. And they're like, no, don't do that, because you're about to leave, and then I'm here all the time. So I think if we are asking patients to challenge, there has to be measures put in place and assurance that it's not going to influence their care or change the dynamic and the trust with their caregiving team.
Yeah, absolutely. And I think they do say, and I couldn't highlight it actually, I should have done. I think they did recognise, I think there were two reasons why they may feel uncomfortable to do that. And one was about the healthcare workers' reaction, and then subsequent the way they would be treated. So yeah, absolutely, both of those things were listed in here when they brought in the wider literature. Yeah.
Thanks, Jude. Just some of my reflections on the paper and when you were going through it with your really good analysis. Interesting how when they talked about the improvement in patient hand hygiene scores, they noticed the increase in people using more soap as well. I thought that was really interesting. And I think it just ticks into, these behavioral things. When you see other people doing things and you think about, oh, okay, maybe I should be washing my hands before I eat my dinner or after I use the toilet. And it just kind of, it's that human behavior side, which is so important in stuff like this, isn't it?
Yeah, absolutely. Yeah, and I did wonder whether, as you went, as the intervention period went on, that more people would be aware of it. More people would know that patients are likely to ask me. If you've got 700 odd people, patients doing these observations, you're likely to be asked if you've not done it already. And that's what I think was missing with some of that data. It would have been great to have for them to have captured when they did have to ask, and when they did have to remind people, and actually capture that as part of their data, because that's kind of missing. And I think that could have been a nice picture to see.
Yeah, definitely. There's some interesting comments in the chat about specialist IPC nurse and not feeling confident to challenge staff in hospital when I'm on admission and feel vulnerable. Also people talking about personal reflection, struggling when loved ones are in hospital and some of the practice was really poor that they observed, and then worried about how that might affect the standard of care, which is something that we've already touched upon. And it is, like you say, when you're in hospital and you feel vulnerable, you need, if you are going to challenge, you need some assurances, don't you, that it isn't going to impact the way that you interact and the standard of care that you receive.
Okay, so question from Jane in the Q&A around how can we empower our understanding of human factors to perhaps change the underlying culture to make it possible and easy for patients to challenge staff around hand hygiene or other elements of their care?
It's tricky, isn't it? I think we've just got to tell them it's okay. And it's quite a simple thing to say to somebody on admission, isn't it? If there's something that you don't feel happy about, or there's something that you are uncertain about, or you'd like a healthcare professional to do, it's okay to ask. I don't think we empower people to do that. And I think what's shocking is just seeing the people that have just said that they don't feel like they can challenge. I don't feel like I can challenge either. Just putting it out there, there's something ultimately wrong there, isn't there? With I don't know whether it's a culture of society. I don't know. People don't like to be told that they're doing something wrong. But yeah, I think we just need to empower better. And I don't have all the answers on how to do that, but we've just got to empower people to be able to challenge. Kindly is the thing. It's got to be done kindly.
Yeah, I agree. That's a big part of healthcare, isn't it? It's making sure that, we're talking to people kindly and we're all humans and we've all got emotions and feelings. Another reflection of mine, Jude, was, talking about how we put interventions like this and make them like common practice. So I have some thoughts on myself, but I'm just wondering what you think is that, how in a busy, environment where there's lots going on and, we might be short staffed or we might have patients with, difficult needs and care. How can we, routinely empower our patients to improve their hand hygiene, do you think?
I think we need buy-in from the top to enable us to do that. I think if we've got buy-in from our, execs, our matrons, etc., to give us that time to be able to do that education and to do that, the time it takes to have those conversations, I think that can help. I think using your quality improvement projects, and again, that comes from having that buy-in from your staff and your leaders to give you the time to do that. But these are really nice little quality improvement projects, aren't they, that we could really take forward. So yeah, we just need a bit of buy-in, and there's lots of my experience in busy settings is that there's lots of innovation, there's lots of people that want to make a difference. How are they being heard? Are there forums where they can put their ideas forward? And it's just having that space to do that thinking, to enable those innovations to come forward, and then working out actually how are you actually going to execute that? Have we got the time? Have we got the resource? And most things, if it's not going to cost anything, most things will be a yes. And actually, something like using patients in this way has cost absolutely nothing. We're not asking for any funding to do this. So actually, it's a win-win, really, isn't it?
It is, yeah.
We shouldn't be thinking like that, but
Yeah. From my own perspective, I was just thinking about, how can we tap into those things that are going on all the time within healthcare, whether or not it's the visit from the healthcare professional to take or the healthcare assistant to take your blood pressure in the morning, or, somebody who's coming around and hand out the meals. Like, that's a real crucial part, isn't it, of hand hygiene is before we eat because of the risk of transmission. So is there somebody, when they hand out the meals, just being able to say, have you done your hand hygiene today? Or, are you aware of it? This next question, sorry, John, is maybe putting the cat amongst the pigeons. I really picked up on what you said about how they didn't talk about the quality of the hand hygiene. So whether or not, they were following the technique that we're all familiar with and, the process. But do you think that actually, maybe I'm kind of eating my own question here, but is it better not just to start somewhere and to just encourage people to get into the concept and principle of washing or cleaning their hands regularly, and then we can maybe build in the technique more if you're talking about from a patient perspective and you're starting at doing nothing?
Yeah, I would say so. I think the fact is that somebody's doing some hand hygiene, so it's going to make some difference, isn't it?
Yeah,
If they've missed the thumbs, it's not the end of the world. It's not great, but if you've missed one part of the technique, at least you've done 90% of that technique. So I think in essence you're probably right, and then it's how do you build that in, because actually it's quite a lot of more investment to educate patients on technique than it is did you do it or not. That's a completely different level of observation, isn't it? And like you say, some of these people aren't quite feeling as well as they could. They're in hospital, so it's actually how much pressure can you actually put on somebody. So no, I think you're right. We've got to start somewhere, and yeah, I think you're right.
thanks, Jude.
So I think one really good element or benefit of this approach is that it gets you around that observation bias challenge with hand hygiene audit that we always struggle with, sometimes known as the Hawthorne effect. That staff behavior is changed just by the process of being observed, and if every patient is silently observing hand hygiene, there isn't that sense of being constantly observed. I was just wondering, firstly, what exactly did they ask the patients to observe? What was the information they were asking the patients to capture in this study? And do you think that was optimal, or if you were doing the study, would you ask the patients to try and record something else about hand hygiene? Do you think it was the right indicator?
I thought the before and after were the right indicators, absolutely, but I think they made it difficult because there was an unclear, like you could tick unclear, and I think where they positioned these dispensers wasn't by the bedside. And I worry about that because hand hygiene, you want it at the point of care, right? So I know you need them in those positions, but for a study like this, I think you would have got an more accurate picture if they had used it that was, propped on the the wall by the bed or whatever. However, they did try, I think, to mitigate that by giving portable hand hygiene, the portable alcohol-based hand rubs that was attached to them. However, they only gave those to nurses and not to other professions. So again, it's not really like for like, is it? So you might have said all the nurses did their hand hygiene before they touched me. However, the doctors didn't, but actually they'd done them all outside before they'd walked through the door. And then you're not really getting the accurate picture. So I think the before and after was right. I think they could have perhaps positioned those dispensers a bit more visible for the patient.
Thanks, Jude. One more question. This is from Nick. Hi, Nick. A regular attender of Journal Clubs, Nick Hughes. Nick, great question. We've talked a lot on the Journal Club about water-free or water-light care. So Jude, Nick's question is, does water-free or water-light settings or care present an additional challenge to patient hand hygiene? And he says, sorry.
Yeah, I'm gonna speak to you later, Mr. Hughes. I think it all depends, doesn't it? It depends on the organism that you're dealing with. So, if you're thinking about envelope viruses, you can't rely on alcohol, right? So then you're just going to struggle, aren't you? But most organisms would, and anything gastro, of course, you're not going to want to be using alcohol either. So, yeah, I guess so. I guess it just depends on what your risks are, I suppose. And I think water-free, I've not bought into water-free. I think water-light is more right. And when I've looked, I was very lucky to be invited to a setting that had gone water-light. And actually it was sink light, not water light. So actually they still had water, but it was sterile water and not just it just was sink light. So I think it just absolutely depends on actually what we're dealing with here. So yeah, I think there might be some risks, but I think we just need to look at that carefully, wouldn't we, on what we're dealing with.
Yeah, I think it's a
Really bad answer, sorry.
No, I think it's a good answer in terms of like trying to understand what it is that you're dealing with. But I guess that we probably want an approach that is going to be as appropriate in that setting as possible. And we've got alternatives as well, haven't we? We can talk about things like wipes. I know there's a big sustainability issue and a big sustainability challenge around that. And you would probably always encourage people to wash their hands where they can get out of bed. But for the people who can't, then it's alcohol hand rub or it's a wipe. So it's just trying to find that balance between ultimately sustainability and what is available to in your current setting. But Jude, we're going to wrap it up. John's just going to finish, but just from me before I pass to John, thanks again for coming, and great to hear insights as always.
Thank you very much.
Thanks, Phil. Okay, so just one final thought, Jude, from me is, do you think that we should all have a systematic program in place now to include patients in our analysis of hand hygiene performance? There may be lots of different ways of doing that, but do you think we should all be doing it now, basically?
I think so. Yeah, I do.
Okay, I do too, but I'm still not quite sure on the how and what the right methodology is, and the upsides and downsides. But Jude, that was fantastic as ever. Thanks to you for joining us today. Thanks to everybody else who's been so vocal on the Q&A and in the chat. So it's always good to hear your thoughts. So next up, October the 8th, Dr. Alexandra Peters will be talking about environmental hygiene. And then following that, on October the 22nd, Dr. James Price will be questioning whether proactive whole genome sequencing for IPC is worth it. Take a look at the website for the up-to-date schedule, the YouTube channel for previous recordings, and feel free to contact us with any inquiries you may have. So with that, Jude, you're brilliant. Thank you. Phil, see you soon. And thanks for joining us.
Thanks, Jude. Thanks, everybody. Bye.